Good afternoon, sir and ma'am, and all the delegates who have joined the program of this Chat with Champion Buddies. Sorry. So before going to the program, I just want to read the guidelines of today's program. Please dedicate this 45 minutes of committed time for each lecture session. Sit in a quiet place and avoid public environments and external distractions and interruptions. Put your phone on silent mode and switch off the camera and Google Meet to avoid distraction. Discuss with your other colleagues and update yourself in case you have missed out anything in the session. Take notes if necessary during the session. Please email us all the queries will be answered before the next session. No in between discussion session will take place. So kindly fill the feedback form at the end of the session, which will be posted in the chat box and claim for the certificate applicants. So as I share the invitation in the WhatsApp groups, so today's topic will want nourish and nurture the minimalistic way. Sorry, due to a microphone problem, I think the last few things which I spoke could not be heard to the other participants. I hope now it's audible to all. So we all know natural tooth are the ideal space maintainers as always. And according to AAPD guidelines, we all know how to prevent the pulp therapy to avoid the pulp exposures. We can do an indirect pulp capping or indirect pulp treatment. So we know various materials which can be used for indirect pulp capping agent. Due to this COVID era, a material which has been popularized because of the maximize effectiveness and also to prevent the irritant from reaching the pulp. So today's speaker will be showing the presentation or some clinical cases with this experience of how to use the indirect SDF as an indirect pulp capping agent in primary molars. So I'm very happy to welcome today's speaker, Dr. Dhanraj sir. He is a reader and associate professor at Sathyabama Dental College, Chennai, and is an exclusive pediatric dentist and clinic head and the founder of Dhaaranis Diamond Smiles Kids and Adults Dental Clinic Madipakkam. He's a former consultant at Peter Planet Children Dental Centers, Chennai, and he's also worked as senior lecturer in the Karpaga Vinayaga Institute of Dental Sciences, and he has undergone various research skills and achievements training and like M squared RP, protocol development, and squared RP systematic review, and also serves the current postgraduate exam university rank holder. And also he has got many best paper awards for the posters and papers. He had completed through online training and research skills through Coursera and WHO courses, which are the famous courses like understanding clinical research behind the statistics and epidemiology and data health indicators in the public health practice. He's a life member of IAPD, ISPPD, IDA, and ISDT, and Foundation of Orofacial Myotherapy. To his credit, he has numerous national and international PubMed Index publications. So, hearty welcome you to sir.
Thank you, Vignesh. Thank you, Doctor.
Yes, sir. Sir, thank you for accepting the invitation immediately, sir. And you can start sharing your screen, sir. Sorry for the microphone problem with this. Yes, sir. Sorry. Sir, the slide is not visible, sir. Can you put in a slideshow mode?
Now it is visible?
Sir, no, sir.
No. 1 minute.
Yes, sir. Yes, sir. Now it's visible, sir.
Is it?
Yes, sir. Yes, sir.
Thank you.
Yes, sir.
Can I go ahead?
Yes, sir. Sir, if any disturbance or any issues is there, I'll just unmute myself and let's sir. So currently, I'll just mute myself, sir.
Sure. Thank you. Very good afternoon. Greetings from Chennai. Vanakkam.
Sir, can you put in a slideshow mode, sir? Sorry, sir.
Slideshow? No, it's not coming in full screen?
Yes, sir. Yes.
Is it?
Yes, sir.
Yes, fine.
Yes, sir.
Full screen is visible?
Yes, sir. Slideshow mode.
Yeah, thank you. Good afternoon, everyone. Greetings from Chennai once again. Vanakkam. I begin this presentation with a small quote. Whatever you may do in your life, do it well. Today's session is about nourish and nurture the minimalistic way. I am Dr. Dhanraj. I am a reader as well as an associate professor at Sathyabama Dental College and Hospital, and I am an exclusive pediatric dentist and founder of Dhaaranis Kids and Adult Dental Clinic, Madipakkam, Chennai. Going ahead with the objectives of the session. So I will be presenting about the known and current concepts behind dental caries with a small introduction, and about indirect pulp capping and what are the steps in indirect pulp capping, and the steps, one of the steps, that is caries removal. What are the current concepts of caries removal? Can SDF be used as an agent in indirect pulp capping? What is the hypothesis behind the SDF which can be used successfully as an indirect pulp capping agent? And what will be the choice of restorative material with my few cases by using SDF as an indirect pulp capping agent? Going ahead with a small introduction, the physician treats but nature heals. This is the famous quote by Hippocrates. Nature always has the tendency to heal and repair by itself. Exploring the biology of the tissues and using that in the practice definitely works good, particularly in dentistry, as the healing capacity is very well pronounced in young primary as well as the young permanent tooth. This has been the trend recent nowadays. Why we want to preserve the vitality? Because the ideal natural tooth is the best space maintainer. By preserving the vitality, we are establishing a functional equilibrium in the oral cavity. This functional equilibrium is disturbed by the most common disease, which is called as dental caries, as you know. In 2010, the Fontana definition states that it is a bacterial-driven, site-specific, multifactorial dynamic disease. But the recent concept, which tells that it is a biofilm-mediated, diet-modulated, multifactorial dynamic disease, according to Pitts et al. 2017, according to the recent Caries Research Journal 2020. So, in putting in simpler terms, dental caries is a continuum. It is a multifactorial, biofilm-mediated, diet-modulated disease. And if there is an increase in the dietary consumption of carbohydrates, yes, it results in the localized destruction of hard dental tissue by the weak acids. The localized destruction of the hard dental tissue will definitely change the microbial biofilm present on the oral cavity, and it leads to the change in balance, which is called as caries balance. This caries balance is influenced by various factors such as the amount of dietary carbohydrates taken, the amount of fluoride taken, or the amount of fluoride present in the oral cavity, as well as the brushing practices too. So if the balance shifts in favor of the disease, there will be more caries. That is, it is mediated. The caries is mediated by a balance of protective as well as the pathologic factors. So to conclude that the dental caries is a continuum process, whereas the drill and fill process, like the past concept, will not fulfill this continuum. So hence the newer techniques have been aimed at exploring the biology of the tissues and inducing the repair or regeneration of the dentin pulp complex has become the new norm. One such biological approach is minimally invasive dentistry. The principles of minimally invasive dentistry is RRR, that is the famous RRR, that is recognize, remineralize, and repair. So the combination of recognizing the carious lesion at what stage it is according to ICD-10 codings, and using a combination of the remineralizing agent as well as repairing the affected tooth structure with the proper restorative material forms the basis for any minimally invasive procedure, which is even can be used in a minimally invasive pulp therapy, vital pulp therapy called indirect pulp therapy, which we call it as indirect pulp capping or indirect pulp therapy. This indirect pulp treatment is a procedure where we leave the deepest caries adjacent to the pulp undisturbed in an effort to avoid a pulp exposure, where this caries affected dentin is covered with a biocompatible material to produce a biological seal. So what are the steps in indirect pulp treatment or indirect pulp capping? The step 1 is caries removal. Step 2 is placement of a biocompatible material. Step 3 is a restoration. And what is the current concepts of the first step, that is the caries removal? The current concepts tell that the caries should be removed in such a way that it should be preserving the sound tissue or the demineralized but remineralizable tissue. That means it may be a host-mediated remineralizable tissue or a material-mediated remineralizable tissue. And the caries removal should be in such a way, that is, the selective removal should be in such a way to avoid the death spiral of restoration. The death spiral of restoration is nothing but that repetitive failures of the restoration leading to the loss of the good sound tooth structure. So we need to avoid such death spiral of restoration, and to improve or increase the longevity of the restoration, we should form a good peripheral seal. What is peripheral seal concept? When you see into, according to Swendick et al. In recent caries, current concepts in caries tissue removal, in deep caries lesion, particularly with vital pulp, the carious dentin should be left in proximity to the pulp, whereas in peripheral, the carious dentin should be completely removed to sound dentin to allow an effective peripheral seal. This peripheral seal plays a major role in success of any restoration. So this is the current concept according to Swendick et al. So how will you assess the dentin, whether it's a hard dentin or a firm dentin or a leathery dentin or a soft dentin? So according to these current concepts, a hard dentin is nothing but where only a sharp cutting edge or a burr can lift that dentin is called as a hard dentin, which can be diagnosed by when a straight probe is taken across, where we see a scratch sound, where we can hear a scratch sound, or a credentine. Whereas the firm dentin is physically resistant to hand excavation, and some pressure needs to be exerted through an instrument to lift it. And the leathery dentin, however, it cannot be deforming when you use a sharp spoon excavator, but it can be easily lifted without much force being required. And the soft dentin definitely will deform with a sharp spoon excavator and yield without much force being required. This is according to the recent recommendations. So what are the approaches for caries tissue removal? There are 4 approaches for this caries tissue removal in deep caries lesion. Non-selective removal to hard dentin is not at all recommended nowadays, whereas selective removal to firm dentin, selective removal to soft dentin, stepwise removal, and sealing in concepts are the 4 approaches. Where we can use this selective removal to firm dentin, if you see that the selective removal to firm dentin is recommended only in the lesions which are not deep, that is, which are not deep, that is shallow or medium deep lesions, that is, which it has not reached the inner third or the inner quarter of the dentin, whereas it is not recommended for deep lesions, where you can use selective removal to soft dentin or sealing in of the caries lesion or stepwise excavation. So you can see a pictorial representation here, where you can see the various strategies of caries removal. The figure B tells you that it is a over treatment where we completely remove the non-selective removal to hard dentin, which is not recommended nowadays. And figure C represents the stepwise excavation, and figure D represents the selective caries removal to soft dentin and you can see the figure E, that is the sealing in of the caries lesion, which is most commonly used in Hall's technique. So according to Swendick et al., if you see a primary tooth, which is a retainable tooth, whereas the caries lesion is non-cleansable, the pulp is vital, and when it is not irreversibly inflamed, you can see the lesion depth, whether it is a deep or shallow or moderate. According to him, the deep lesion is nothing but where it has approached the inner 1/3 or 1/4 of the dentin, or there is a risk of exposure when we expose the dentin, you can go ahead for a selective removal to soft dentin. Whereas on moderate or deep lesion, even in deep lesion, you can go for a Hall's technique. In shallow or moderate lesion, that is, if it does not reach the inner third, that is, it is in the outer third of the dentin, no risk of pulp exposure. Either you can go for a Hall's technique, or you can go for a selective removal to firm dentin or ART or non-restorative caries control. The stepwise removal or excavation is recommended only in permanent tooth, not in primary teeth. So I'm not going to explain about it. So what are the armamentarium required for the stepwise or the selective caries removal? The rubber dam isolation is must. You have to use chemomechanical caries removal agents, sharp spoon excavator. Particularly, I personally use Osan company, and the size preferred is 38 and 39. So the chemomechanical caries removal agents most commonly present in the market are Kericare, Brix 3000 and Kerifix, which is most commonly composed of papain gel, which aids in the selective caries removal of the soft dentin and not removing the firm dentin. So this is how we use the chemomechanical caries removal agents in our practice. So you can see a video here how we use this selective caries removal agents, that is chemomechanical caries removal agents. So you can see the soft dentin, that is the soft dentin, the peripheral tissue, the lesions have been excavated with the help of sharp spoon excavator. You can see there the firm dentin is not removed or not yielding, which is aided with this chemomechanical caries removal agents. So the next step is a biocompatible material to be used as an agent for IPC. Various agents have been reported according to the reference manual of pediatric dentistry. Dikel, bonding agents, and mineral trioxide aggregate and biodetin have been successfully used for IPC. And the rationale behind every success of indirect pulp therapy is, as long as the tooth remains sealed from the bacterial contamination, the prognosis is good for caries to arrest and reparative dentin can be formed to protect the pulp. So ultimately, the peripheral seal plays an important vital role in regeneration and repair of dentin. So the indirect pulp therapy is indicated in deep caries, and when there is no pulpitis or with mild irreversible pulpitis, and the pulp is judged by clinical and radiographic criteria to be vital and able to heal from the caries insert. So these are the indications for indirect pulp therapy. So the objectives of this indirect pulp therapy is to preserve the vitality. The restorative material should completely seal the dentin from the oral environment, no post-operative symptoms and no radiographic signs. So in post-COVID era, the most commonly used material and its most popular material in particularly non-aerosol dentistry is the silver diamine fluoride. Silver diamine fluoride is used in Japan in the early 1600s, and in 2015, FDA approved the use of silver diamine fluoride for dentistry. And silver diamine fluoride is an alkaline, the pH of 8 to 9, and its composition of silver of 24 to 28% and fluoride of 5 to 6% with ammonia as a stabilizing agent. So what is the mechanism of action of silver diamine fluoride? Its composition of silver acts as an antimicrobial agent. The silver combines with the hydroxyapatite present in the enamel as well as in the dentin, and it forms silver phosphate. Silver phosphate further reduces to silver ion so that it blocks the dentinal tubules with silver ion so that there is a reduced microbial invasion, and also the formation of, because of the higher amount of fluoride release, the stronger and stable fluorapatite is formed, and also the silver diamine fluoride reacts with the organic component present in the dentin, such as it inhibits the enzymes such as matrix metalloproteinase or cysteine, cathepsin cysteines, so that it prevents the degradation of the demineralized dentin. So many clinical studies have proven that have been started to find the use of SDF as an indirect pulp capping agent. An ongoing randomized control trial have been running for an indirect pulp capping of young permanent molars, and 10 years back already a clinical study have been done where the silver diamine fluoride and glass ionomer type 7 and calcium hydroxide have been compared clinically, and it has been shown that the SDF can be a potential indirect pulp capping material. Whether when we use this SDF as an indirect pulp capping agent, a question arises in our mind that whether it can be biocompatible or whether it is injurious to the pulp. A recent systematic review in 2022, Zeneldin et al., he has in his results and conclusions, SDF as a direct application on the pulp, definitely yes, it is injurious to the pulp and it is toxic to the pulp, whereas indirect application of SDF produces mild irritation to the pulp, which ultimately reinforces the pulp defense mechanism for resulting in the formation of tertiary dentin, which can be seen in that the odontoblasts-like cells were observed where the SDF was applied, and it was an intensively active basophilic nuclei was seen in the odontoblast-like cells. So the hypothesis behind the silver diamine fluoride, which can be used as an indirect pulp capping agent, why it can be used? Because the presence of zombie effect, that is the biocidal effect of silver affecting the bacterial cells, the killed bacterial cells attack the living bacterial cells present in the infected dentin, so that it has a zombie effect. So it prevents further growth of the microbial organisms in the remaining dentin, and it reinforces the pulp defense mechanism and resulting in the formation of reactionary or tertiary dentin formation. So after applying the STF, what could be the choice of restorative material? Either you can use GIC type 9 or an RMGIC. My personal choice, I use a capsulated form of GIC rather than the self hand mixed one. And you can use the GC code, which is a self-adhesive light cured resin code. And under certain circumstances where peripheral seal may fail, you can go for a stainless steel crown. So if we use GIC or RMGIC, whether the STF has any influence on the bonding strength or the restorative ability of glass ionomer, in a recent systematic review, it has been concluded there is no significant influence on the bond strength of dentin to the glass ionomer cements, and there is no clear conclusion as there was methodological heterogeneity in the included studies. If we use an RMGIC, whether we can use a light cure, we have to light cure sometimes, whether the light cure has an effect on the mechanism of action of STF. Does it reduce the activity of STF? According to many in vitro studies, the silver deposition in infected dentin increases, and the micro hardness has been shown to increase in the infected dentin when the light cure has been used. That shows that the remineralizing ability have been increased, and whereas there is no change in antimicrobial effect according to one study, and there is no change in the depth of penetration of silver in the primary teeth according to Tucci et al. The recent study. Another question comes because STF causes black discoloration because of the deposition or the precipitation of silver phosphate on the dentinal tubules. Can STF plus potassium iodide can be used? A recent systematic review has concluded that it doesn't have, because few studies tell that it has reduced the antimicrobial effect of STF, but there is no enough evidence for that, because it minimally reduces or there is no effect on the antimicrobial effect of STF. But it decreases the staining by 25% in primary dentition, but no results have been shown in the permanent dentition. But these results should be taken to caution, but because the marketed product which is available, such as Revastar, has no optimal concentration of potassium iodide or any protocol specified for potassium iodide application. So in IPC, STF plus KI should be, furthermore clinical trials should be done to find its efficacy in IPC. Why we are talking more about indirect pulp therapy, and why we are because as per the AAPD recommendation, it has been shown that indirect pulp treatment has shown to have a higher success rate than the DPC, that is the direct pulp capping or pulpotomy, in long-term studies. Indirect pulp therapy also allows for a normal exfoliation time. So therefore indirect pulp therapy can be chosen instead of DPC or pulpotomy when the pulp is normal, or as a diagnosis of reversible pulpitis when there is no pulpal exposure. So going ahead with my clinical cases, a few of the clinical cases where you can see a 3-year-old preschooler diagnosed with early childhood caries in 7-4 and 8-4 with pits in 7-5. You can see the 7-4-7-5 radiograph here, and you can see the radiograph shows that it is an ICDA score 6. And the patient doesn't have any pain at all. Occasional sensitivity was seen. Sorry, this is 8-4-8-5. Sorry, it is a lower right back tooth region where you can see it is an ICDA score 6. So when you see this lesion, when we isolated this lesion and a rubber dam with the flexible approach, and the 13A winged clamp were used with the split dam technique, and the liquid dam was used with peroxidam. You can see the lesion there. It is after rubber dam isolation. You can see that when we selectively remove the caries with the help of spoon excavator and chemomechanical caries removal, you can see that as I told you that the firm dentin will not yield to the spoon excavator, and it was very resistant. There is no removal. There is no removal of the caries dentin there. That showed that it is a completely firm dentin. So only the peripheral lesion was excavated, and the firm dentin you can see there. So after excavation, we applied the SDF and GIC restoration was done. This is the immediate post-op radiograph of 8-4 after the GIC restoration. So this patient have been reviewed after 3 months, fingers crossed, whether we thought that whether it would have gone for a pulp exposure or there is any resorption. And you can see that after 3 months, the margins, yes, the margins are discolored because of the SDF. And when you see the pre-op here, this is the pre-op and this is the immediate post-op after the restoration. The patient didn't have any clinical sign or symptoms, and the radiograph was after 3 months. You can see that the radiograph was, there was no clinically or the radiographically there was no symptoms of pulp exposure or any periapical symptoms was seen. The second case, a 5-year-old child. Here you can see the clinical picture of 8-4-8-5 as well as 7-4. 7-4 went for a pulp therapy because it was involving the pulp. The 8-4 and 8-5, you can see the pre-op intraoral periapical radiographs, where you can see that the 8-4, the IDAS code, where this can be called as because the inner third or the inner fourth of the dentin has not been explored or reached there. So it is a shallow deep caries lesion or a moderate deep caries lesion. The 8-4 and 8-5. So here we can excavate, selectively remove the caries up to firm dentin according to the recent consensus. So the rubber dam isolation was done. We used the same split dam technique. The 13-year winged clamps were used, and the application of carie care was done. And you can see the video here. So the periphery has been the caries removal, the periphery has been done. You can see there is a resistance to pressure. There is a pressure for spoon excavation. You can there is a resistance to the spoon excavator tip, and this shows that it's a firm dentin. This shows it is a firm dentin. The peripheral caries has been excavated, and after selective caries removal, you can see that the complete shining dentin, that is which shows that the firm dentin. After that, SDF has been applied, followed by the glass enamel type 9 restoration have been done. The third case, and you can see the pre-op of this case, that is the 8-4-8-5, and the post-op pictures as well as the radiographs. You can see a good seal of the JIC in 8-4 as well as the 8-5. This patient has been under follow-up. There is no clinical or any clinical symptoms till date. The patient have been called twice. Whether they had any pain or any swelling, we didn't have any post-operative pain symptoms. So the next case, it is a very good case where in a 5-year-old girl, you can see the pre-op clinical and the radiographic pictures. This shows that the 8-5, you can 7-5, sorry. The lower left back tooth region, you can see the code 6, ICDS code 6. Here the inner 1/4 of the dentin have been very close. It has approached the inner 1/4, and you can see the ICDS code 4 and 7-4. So we planned for a rubber dam isolation here, and the winged retainers have been placed with split dam technique. The selective caries tissue removal with the help of chemomechanical caries removal agents, and you can see this case which has been posted before. So you can see that this soft dentin have been excavated, selectively removed in the periphery, and the center of the lesion has been left intact without touching, because the chemomechanical case removal agent didn't, with the help of that, it didn't yield. So we saw the soft dentin was left near the pulp, and you can see after caries excavation and after the STF application, as we can see that the lingual as well as the mesial proximal surface of 8.5, we couldn't get a proper peripheral seal because it may lead to micro leakage. We doubted. So in such cases, we go for. I have opted for stainless steel crowns. The SS crown has been placed, and this is the post-op of 7.4 and 7.5. Till date, the patient has been under review. There is no clinical symptoms or post-operative pain or swelling. So the patient is fine, and we are constantly keeping them under follow-up. So the take-home message from these cases, as well as my experience with these with the STF as IPC, the proper case selection plays a major role. That is a deep caries lesion, where we should see carefully that whether there is pulpal involvement or any radiographic changes are seen, that should be taken into account. And the another take-home message is, when the selective caries removal, the soft dentin selective caries removal can be done for the lesions approaching the inner 1/3, that is the inner 1/3 of the dentin has been approached, you can go for a selective caries removal to soft dentin, whereas selective caries removal to firm dentin is recommended in moderate or shallow deep caries lesion, where it has not approached the inner 1/3 of the dentin. The armamentarium for proper armamentarium should be there. You should have a chemomechanical caries removal agent, a sharp spoon excavator, and proper peripheral seal should be done properly, and you should check if there is, in certain cases, if the peripheral seal cannot be achieved, you can go for a stainless steel crown, so that to improve the success of this IPP. And the hypothesis behind the STF, yes, the zombie effect, as well as the mild irritation when the STF is indirectly applied, the reinforcement of the pulp defense mechanism happens, which results in the formation of reparative dentin or reactionary dentin. To conclude, using silver diamine fluoride, you can nourish that the demineralized dentin with fluoride, so that the remineralization happens, and nurture the demineralized dentin with silver, so that it can prevent the further microbial damage. Because of the silver has a very good antimicrobial activity, and we can use a combination of chemomechanical caries removal agent and proper armamentarium, so that it can be minimally invasive. And I hope this is the smart way for doing an indirect pulp capping or indirect pulp therapy in primary molars. I thank and I dedicate this presentation to my father, who is not materialistically present with us, but he always blessed me. And I am thankful to all my patients who have successfully cooperated for the procedures and cooperated for the post-operative and radiographs as well as pictures. And I thank my clinic team who have done many things by proper documentation. And last but not the least, my family members, my daughter, my wife, who particularly takes care of all the documentation properly and the administrative side in my clinic. And last but not the least, I am blessed to have mentors like Dr. Muthu sir and Dr. Prabhakar sir, who is my teacher, who is my postgraduate teacher, who in my life. I'm blessed to have two mentors who always guide me when I'm deviating from the path. And thank you once again for Team Sriher and Muthu sir for giving me an opportunity in this presenting in this session. Thank you once again. And I finish this session with a quote: when you don't know what to choose, just show total involvement in everything that you have. Then life will choose, and it is never wrong. Thank you for the patient listening. Thank you. Over to you, Dr. Vignesh.
Thank you for wonderful presentation, sir. I have a few questions, but I come at last. So it's open for all the participants. If you have any questions, you can unmute and speak, or you can post in the chat box. And if any participants doesn't have any questions, you can just Fill the feedback form which has been posted in the Google form link has been posted in the chat box. You can just fill it in, claim the certificate of participation. Any doubts from the postgraduates? Yes, Dr. Suma. You can unmute and speak, ma'am. Or you can post the question in the chat box.
It was a wonderful presentation, Dr. Dhanraj.
Thank you, Dr. Suma.
I just wanted to know whether the placement of STS will it interfere with the GIC?
Oh, that's what many studies have proven, that there is no influence on the bonding ability of GIC to the dentin. Yeah. And yet there is no much conclusion, because systematic review has not shown much evidence on that, whether there is an influence or not. Yeah.
Thank you so much.
Sir, one more question has been posted in the chat box. Can SDF be placed directly without selective removal of caries if the patient is uncooperative?
Yeah, that is how the smart restoration have been done in uncooperative patients. That is the silver modified ART, where they minimally excavate. Yes, you can do, but I prefer usually a selective caries removal, because most probably the remaining dentin plays a major role here, because the success may be determined by the removal of caries tissue rather than the SDF alone. Yes.
I hope Dr. Garima Jain ma'am, sir, I answered the question. Thank you for the questions posting in the chat box. And any other questions from the participants? From the postgraduates, undergraduates? Sir, I think if any questions is there, they would have posted in the chat box. So I will ask in between time my doubts for the clarification, sir. Can I ask?
Sure.
Sir, as Dr. Garima Jain ma'am told, without selective removal of caries, for example, if the patient is not willing for ECC under general anesthesia for remote rehabilitation, so we apply STF without or with selective caries removal if the patient is very highly uncooperative. So what will happen, how much time you have to, any standard time is there for the follow-up, sir? If there is no pulp involvement is there, but still patient is not willing for the proximal caries, so we apply SDF. So there is a particular follow-up time to check and observe whether any further caries progress is there?
No, I don't think so. It's not clearly given any protocol for review or recall of such cases. But I particularly, in my opinion, if we don't remove selectively the caries tissue, the peripheral seal will not be there. See, what is the peripheral seal concept tells that if the sound dentin on the peripheral surface is done well, and you place it properly, place SDF, then definitely the tissue can get remineralized. If the peripheral seal is not proper, that is, even you have not excavated the dentin, the infected dentin or the caries tissue selectively, you have not removed it up to the sound dentin, then the success of that any minimally invasive therapy like an indirect pulp capping will not be good. That's what the peripheral seal concepts say.
Okay, sir. Yes, thank you, sir. And the next question is, and if the patient is becoming uncooperative while placing the dams or clamps, but we have to apply the anti-years, the STF. So what we'll do is we'll isolate with the cotton rolls with the cheek retractor, and we'll apply a Vaseline around the gums, and then we'll apply. So any other strategy is there to avoid the staining to occur in the soft tissues? apart from applying wax?
No, that's the strategy everyone uses, right?
Any other
Most probably,
technique?
and in proximal lesion, we can use some floss.
Ah.
We use a floss technique, and we used to use for the proximal caries lesion. And that too, you have to be very careful while, because you know that floss you should apply only at that proximal surface. You should apply the SPF. Otherwise, it may cause discoloration of the cheeks when you pull it out. Yeah, so that is one thing which we can when we use SPF, we should, that is the recommended technique. Yeah.
Okay, sir. And the one more thing, while the split dam technique which you showed, you'd use a liquid dam, right, sir? In the
Yes.
Okay. And any other specific pedo clamps you recommend, sir?
I prefer usually wingless clamp. Sometimes in uncooperative patient, in my experience, what has happened, they try to close the mouth. Even when we use mold mouth prop, we used to close the mouth. That sometimes the wingless retainer is comfortable actually, but it tries to come out. So I prefer wingless clamp. Winged clamps usually in uncooperative patients. Wingless clamps can be used for Coltine. I use Coltine. I prefer Coltine. It is good.
Rubber dams you're using Coltine?
I use Nictone as well as Sanctuary. I use both Nictone as well as Sanctuary. I use.
Coltine is a rubber dam clamp, and the rubber dam sheets you're using Nictone.
Rubber dam sheets I'm using is Sanctuary and Nictone. Yeah.
Okay, sir. And any other one more thing, sir? As a clinician, you also know, but whether we have to tie the floss, sir, in case of the accidental incision.
Yeah.
The floss has to be tied and the clamp.
Yeah. Definitely you have to floss. Yeah, definitely you have to floss it. Yeah.
Yes, sir. Yes, sir. One more thing, and the last thing is, can we the cases which you showed is excellent presentation in the primary molar, sir. Same thing can we apply it in the permanent molar, and we could see it will be fine, sir? We are trying.
Definitely
But,
the trial is running.
Not the follow-up is in this process. I just want to know whether any studies or systematic reviews is there for the, because I know you have done an essay writing also in the IS50. I think similar to STF.
No, I have. I personally say there is an ongoing RCT, randomized clinical trial, running in young permanent molars, indirect pulp capping, SDF in combination with KI, that is potassium iodide. Also SDF is also used. The combination as well as SPF has been tried. Most probably the results will be out in 2022 end, most probably. So I am also waiting for that. And even the few studies have shown in MIH molars, particularly in MIH molars, STF have been used and SS crowns have been placed. Few studies have been there, but still there is no systematic review on this. Yes.
Okay. And no RCT also is there?
RCT, yes, now only have started. We have to see them. Yes.
Okay, sir. Thank you, sir.
Yes,
and one more question. Yes, sir. One more question to the participants to tell about the reverse effect in case of any silver allergy for the patients.
Adverse effects, definitely there will be irritation and inflammation will be there. Itching will be there, obviously, silver allergy. So definitely in such cases, you should ask whether they have a silver allergy previous history should be there. You should ask before using silver diamine fluoride. That is the consensus. Before applying SDF, you have to explain everything to the patients, what could happen, whether they have a silver allergy or not. So definitely you have to explain them, and then only you have to do the procedure. Consent should be got. That's how. In such cases, you can tell them to take, because the silver allergy has come, means definitely we have to go for an anti-allergic medication. That's how.
Okay, sir.
Yeah.
Thank you so much, sir. I think the question sessions has been done. So no questions from the participants. If any questions has been posted, I'll just share through WhatsApp or mail, sir. I'll share the recordings to you, sir. You can post on the YouTube so that the others can view through the YouTube channel or anything in the social media from which you can go through it. And I'll share the hard copy of the certificate and the feedback summary through mail by today evening or tomorrow morning, sir. So before concluding today's program, I just want to share the next program invitation before sharing the certificate for the sir. So this is the next program invitation, which is scheduled on 15th June at 2 to 3 p.m. By Dr. Vivek sir on early childhood caries, logical insight and its management. So kindly request all the participants to mark in your calendar. It will be posted in the WhatsApp groups priorly, as we do regularly for the POBTs and Tamil Nadu media dentistry groups. And sir, I hope the certificate is visible to you, sir. certificate of appreciation for delivering a guest lecture on Nourish and Nurture the Minimalistic Way, organized from Department of Pediatric and Preventive Dentistry. On behalf of team, I'm just handing over the certificate, the soft copy, and I'll share through WhatsApp and also attach through the mail, sir. And the hard copy will reach. It will reach by 2 weeks of time, sir.
Thank you. Thank you.
Thank you for the time, and thank you for showing the excellent case documentations, which is we all are lacking, and we have started it, so we are in the process, and we'll show it soon. Thank you, sir.
Thank you.
Thank you so
Thank
much
you,
for
Doctor.
today. Yes, sir. Have a good day, and thank you all the participants who have joined the program for continuous support for joining continuously. Thank you. See you all in the next program on 15th June. And if any other queries is there, please